to a motion each may speak for up to 10 minutes, and other members each may speak for up to 7 minutes. I'm obliged to direct any member speaking in excess of the specified time to discontinue. Second member's motion, dissolving the hospital authority. Members who wish to speak in the motion debate will please press the request to speak button. And I'll call upon Dr. Leung Ka-lau to speak and move the motion. President, I move that the motion as printed on the agenda be passed. 2 years ago, I already suggested that the HA be dissolved. At that time, there were 5 amendments. Many colleagues asked the HA to increase resources and manpower. There was no division and all the amendments were passed. All of us were very happy. 2 years have elapsed. What about our feeling about the services of the HA? Have we changed our feelings? Today I'm moving this dissolution motion to see whether colleagues have any good solutions to rectify the unsatisfactory aspects of the HA. The public asks that more resources and more doctors be given to the HA. We've always heard these requests. To what extent should resources and manpower be increased? Rational persons will inspect past funding allocation, waiting time, number of patients, etc., etc. Prolonged waiting time is mainly because of uneven allocation of resources, not insufficient manpower. Tabled today are a few tables with statistics. Number 1, the HA always says that there's insufficient manpower with serious wastage. But in the past 10 odd years, every year we had more doctors. There are more new recruits than those wasted. So service increases are bigger than decreases. In 2004-05, there are 2,456 doctors. By a few years, there were over 5,100 doctors. For specialist clinics, resources increased tremendously. As for the number of inpatient daycare, a jump of 4% from 5.2 million to 5.4 million people. Why is it that with boosted service quantity, there are still problems? Let's look at the waiting time for new cases. For the 7 clusters of hospitals, there are huge differences. For the orthodont, there are 107 weeks for waiting time. For Hong Kong Island West, only 15 weeks. Medicine, 91 weeks. But in Kowloon Central, 19 weeks only. Why is it that the waiting time varied so much? It's because different clusters receive different amount of resources and manpower. They're directly related to waiting time. In Kowloon East, every year per 1,000 persons, only $3.95 million. For Kowloon Central, every year per 1,000 persons, $10 million. A twofold difference. As the funding allocation varies so much, why can't we rectify the situation? Let's look at the 4th table. In the past few years, for the funding allocation for various clusters, for so many years, the administration has been continuously increasing resources for the HA. But among clusters, there are not much differences. For Kowloon East, they take care of 14% of the overall population, but for so many years, it's only 10% of resources for them. For Kowloon Central, it takes care of 7% of the population, but resources 14%. Therefore, we can see that no matter how much resources and manpower are given to the HA, if the allocation method is not changed, then forever we can't change the waiting time of those clusters receiving less resources. And usually our feeling is related to the worst clusters, that is, those with the longest waiting time. So complaints are normally from Kwun Tong, Kowloon East, New Territories, West, Chun Mun, Yuen Long, and now NT East in Prince of Wales Hospital. Regrettably, extensive waiting time has resulted in public pressure for the government to increase more resources and manpower for the HA. But because of maladministration, the HA has been rewarded, so there's no incentive for the HA to rectify the situation. In the past 2 years, between the HA and the government, they heard my statistics, so they suggest the rationalization of uneven allocation of resources. They say that for certain clusters there are specialist services for liver transplant, for example, at Queen Mary Hospital. Well, every year only tens of millions of dollars are spent on liver transplant in QMH. I think that only accounts for less than 5% of the overall resources for it. Why is it that it gets double the resources for other clusters? For inter-district patients, I tried to seek statistics from the government. Table 5. Kowloon Central does take care of patients from other clusters, but mainly for Kowloon West. It takes care of more Kowloon West patients than its own patients. For Hong Kong West, it mainly helps Hong Kong East to take care of patients. So Kowloon East, NT East, NT West are left on their own. They're just like orphans. Their waiting time is still very long. A few months ago, the CE proposed a list on enhancement of services. It seems that he wanted to shift patients from clusters with long waiting time to clusters with shorter waiting time. This indicates that the government only adopts stopgap measures to address problems. Take new cases as an example. Well, I'm just citing those cases as examples. For new cases, after waiting, patients have to consult at the clinic again. Maybe they have to wait for physical examination or even operations. That accounts for a small portion of the HA services, about 3%. For new cases, it's only about 10% of the overall number of patients seeking consultation. So, for new cases, it's not that difficult. At the same time, why is this not useful in solving problems? Because in terms of funding allocation, nothing was done. What I mean is, for clusters with short waiting time, originally they had ample resources, but they felt that they're efficient in their services. Therefore, their waiting time was short. And then they were given more patients. They felt that they were punished. So very soon, they would adopt various methods to lengthen the waiting time so as to bind the patients. They don't lose out because no matter how much they do, they get the same level of funding. So how are we going to resolve this problem of uneven allocation of resources? There are a number of options. Before we opt, we must not forget the past contribution of the HA in terms of medical quality. They contributed a lot to society. But we have to look ahead. I'm not targeting individuals or any institutions. I'm targeting the mechanism. Should we improve or dissolve the HA? It depends on our knowledge about the HA. I would like to raise a few points. Number one, HA is not the only arrangement. I mean, one single institution coordinating all public medical and healthcare services. It's the buyer and at the same time the seller. So in providing services, its considerations are focused on its own interest. It may not put patients' interest first. As I said just now, it's better to have long waiting time. Other people will strive for more resources for them. Why should they handle the problem? If they handle the problem, they'll get less resources. Secondly, the HA is too huge in organization. 40 hospitals, hundreds of clinical departments. Instructions may not get directly from the senior level to the lower level. in terms of policy implementation. HA expenditure is rather high. I draw comparisons between it and the Education Commission. Don't forget that even if we dissolve the HA headquarters, each cluster still has a very huge administrative structure. There are 3 tiers: hospitals, clusters, and then headquarters. They all have their own chief executives. So, in accordance with the district population and the trend of patients, the government can directly procure services from the clusters and institutions. Internationally, this is a rather common option. This arrangement is money follows patients. And then among clusters, there will be competition. If a cluster does well, it can gain more patients and then more funding. Another advantage is that if the government directly procures services from them, we'll participate more because we'll be directly under the monitoring of the LegCo. What are the demerits of dissolving the HA? Well, I do have feelings about the HA. I believe the Secretary has stronger sentiments about the HA because it's been there for longer. Well, I'll listen to other colleagues first before I speak again. Thank you. I now propose the question to you, and that is that the motion moved by Mr. Leung Ka-lau be passed. 2 members wish to move amendments to this motion. This Council will now proceed to a joint debate on the motion and the 2 amendments. I'll invite Dr. Fernando Chung and Mr. Albert Ho to speak first, but they may not move amendments at this stage. Now it's already 9:30 p.m. After the 2 members have spoken, I'll ask the Secretary to speak, and then I'll suspend the meeting till tomorrow morning.
Dr. Fernando Chung. President, grateful to Dr. Leung Ka-lau for moving this motion of dissolving the hospital authority. This is an interesting motion. I'm sure that Dr. Lau is pretty serious. I think this is a rather extreme measure. Do we have to disband the hospital authority, or should we just carry out some reforms? I have to struggle a bit when I look at this motion. The hospital authority has all the standards to monitor the quality of service at hospital authority at the hospitals in Hong Kong, and this function is indispensable because otherwise the quality of healthcare services will vary considerably between districts. There are certain people who are wealthy and who can afford certain services, and if there is a discrepancy in the provision of service, then I can't find it acceptable. But the hospital authority is really so unwieldy, with 60,000 staff members, like Dr. Leung said. I think as a government, if it is a government department, then it is a body with the highest number of directorate staff. I think the number stands at about 600 with an annual salary of close to $2 million. Should we conduct a review on this massive entity in the form of the hospital authority, or should we disband it? Let's have a look at the performance of the HA. At the very beginning, the HA upgraded the services of the hospitals. It rectified a lot of the undesirables. In the old days, we had to grease the palm of even the stewards of the hospital wards, and now we can get pretty high quality services for minimum payment, I think the hospital authority should deserve its credit. But we have experienced some economic ups and downs. The government has not made any additional investment in healthcare services. There are problems. Dr. Leung said that it may not be a case of manpower problem. It's rather the parochial thinking of different clusters, and that explains the discrepancy in the waiting time between various clusters, and also the diverse standard of services. I go along with Dr. Leung in his analysis. The problems are really disastrous for the members of the public. Now they have introduced the telephone appointment system. Many senior citizens and many patients who rely on public sector services will find it very difficult to make the appointment. They have done away with the queuing system. Mr. Donald Tsang was questioned why the senior citizens had to get up early, and he, in a fit of pique, abolished the queuing system altogether, and that the specialist outpatient clinics are witnessing longer and longer waiting time, and the consultation time is getting shorter and shorter. Can we still maintain the low charges? Since the introduction of the drug formulary, we have seen a lot of drugs that have become self-financed drugs. If you look at the front page of an Apple Daily today, there is a mother who begged for donation for her target treatment for her lung cancer. I mean, she is only able to get 3 months worth of donation. We get to see this every single day. We can't help questioning why in Hong Kong, being such an affluent society, still sees a lot of people begging for medical drugs, and there are some surgical operations that have to be subject to waiting time of 3 to 4 years, and people's conditions degenerate during the time of waiting. The A&E departments, people will have to wait for 5 and 6 hours. Half of those waiting in the A&E departments will have to be waiting for 5 hours at Prince of Wales. Medical blunders are also increasing. Last year, the number has increased by 30% compared with the year before last. And all these indicate that since its inception, the hospital authority has not conducted any review of its governance for 20 years. What comes in for a lot of criticism is that they are fattening the top echelon while at the expense of the lower one. There are bonuses are being dished out, in particular during the SARS epidemic, when the whole of Hong Kong was on a high state of alert and the economy hit the doldrums. The senior echelon of the hospital authority were awarded bonuses. The bonuses have been scrapped eventually, but the pay has been boosted. In 2010, there were frontline staff who had a pay cut of 5.38%, but the top 5 executives of the HA had their annual salary close to $21 billion, a rise of 11%. They see a pay rise, while others are seeing a pay cut, and the pay rise is 3 times, 4 times that of the lower grade staff at the lower rank of the hierarchy when they get a pay rise. This is like a fiefdom, and the unofficial members are appointed by the government, there is a lack of transparency, there is a lack of involvement of the patients. Now, even for the directors of the HA, they are flying first class when they go on business trips. I think it is important to involve the patients in the governance, and the democratization of the management will be very important. The review of the drugs and the mechanism for this, the administration has never allowed the patients to be involved. On May the 23rd, the secretary came before us and discussed the drug formulary, and he went so far as to say that he had to rule out all these people with vested interest in the review mechanism. All these people with vested interest include patients and patients' organizations. The secretary said that if the patients are there, it would be a bad idea if the patients start crying complaints. I'm wondering why the secretary considers the patients are vested in interest parties and deny them the opportunity for involvement. I think the doctors are the people with the biggest vested interest. I don't know how much interest has been given to the doctors by the drug pharmaceutical companies. The patients are involved the world over in the governance. So we feel that today we have to make the HA more transparent and allow more patients or patients' organizations to be involved. Once the HA is dissolved, I don't think we should implement the system of money follow the patients. I think it is time for us to reform the HA and not so much to dissolve it.
Mr. Albert Ho, in my amendment, I've suggested a number of reform options. When I compare them with those of Dr. Leung Ka-lau 2 years ago, they are very similar. I don't want to see in 2 years' time I have to move a similar motion to suggest that the HA be dissolved. I hope that the HA can respond to reform expectations. Yes, the HA is very important. In the past, public sector doctors have contributed a great deal to public health. We recognize that. But today we're asking whether the administrative structure of the HA should be addressed, and the problems are important. I suggest we enhance the representativeness, transparency, and accountability of the HA, including appointing more elected public opinion representatives to the HA and the hospital governing committees of district hospitals to improve governance and to clarify the powers and duties of the HGCs to enable them to fulfill the governance function. The HA is a huge institution with a lot of staff members. LegCo monitoring is rather indirect, but every time we're giving it a one-off funding allocation. Here we can only ask questions in this council, but we cannot forcefully request the HA to address social demands. As for HA governance, the structure lacks public opinion representatives. Even the HGCs of district hospitals have refused to appoint elected district councillors into the HGC to monitor hospital services. Why should that be so? The HA is providing public sector services. Same for the Housing Authority, but the Housing Authority has a high degree of transparency. At least its plenary meeting is open to the public. The media can report on their meetings. So we should enhance the transparency and accountability as well as representatives of the HA. Secondly, I ask that We should make public HA's existing manpower establishment and planning and streamline its administrative structure and review its remuneration and employment systems, and to avoid fattening the top and thinning the bottom. Just now, Dr. Leung Ka-lau already cited some figures, so much so that the HA has given us the impression that it has fattened the top and thinned the bottom. In recent years, the administrative expenses of the HA were far higher than the increase in services. Between 2011 and 2013, the overall manpower level of the HA in those 2 years were 61,000 and 63,900. For administrators, there was an increase of 14%. So the headquarters have expanded. But relatively speaking, the number of frontliners has not been increased proportionately. In those 2 years, for the professional and administrative personnel in the headquarters, their emoluments are over $600 million and over $800 million respectively, a rise of 20%. But the overall salaries of the whole HA were far less than those for the administrators. So that creates the impression of fattening the top and thinning the bottom. So repeatedly we asked in the panel of health services that the overall remuneration packages, the ratio of staff members in different hospitals, etc., should be considered, such that in future the HA can attain its service targets. At the moment, its establishment is not made public. It's just like the government structure, establishment, and financial allocations should be made public. Thirdly, I asked the HA to formulate a fair and reasonable funding system and allocate funding to respective districts and hospitals in accordance with the population sizes of and numbers of patients and types of diseases in various districts. At the moment, we don't quite understand the clustering system. What's the main objective? How does that match with financial allocation? But one point is clear. If we look at each and every cluster and then their respective population size, they don't match. For some districts, they have a higher degree of allocation. Let's look at patients and beds. Hong Kong West serves 530,000 people, over $3.6 billion. For NT West, per 1,000 persons, 1.9 beds. Hong Kong West, 5.7 beds per 1,000 patients. But of course, the HA can offer explanations. However, no matter how they explain, we'd like to ask whether or not each cluster receives a similar level of resource allocation. Many of us feel that that had not been done, even after considering your explanation. The impression we got was that there's duplication of functions among the clusters, in the headquarters, and in individual hospitals. There are factional phenomena. There are struggles among different camps, so to speak. And very often, if a certain faction or camp is making a lot of voices, then it gets more resources. If there's no transparency, that's the impression of outsiders. If outsiders feel that the system is unfair, then the credibility of the HA is undermined. Number 4, I suggest that on the premise of protecting patients' well-being, the HA studies whether it is necessary to retain or reform the cluster system. Take demographic structure as an example. In Sai Kung, between 22 to 40 years old, there are 36.3% of such persons. So they're rather young. Yao Chin Mong, people are more aged. For Kwun Tong, only 29% of beds are in Kwun Tong for GNO. Therefore, other clusters may have to go to Kwun Tong for deliveries. Of course, it's claimed that it's very difficult to employ doctors these days. As for services provided by the clusters, the impression is that there's an uneven provision of services. Let's look at waiting time. Kowloon East suffers most. For orthopedics, a waiting time of 107 weeks. NT East, for ophthalmology, again, dozens of weeks. NT East, 63 weeks for orthopedics. So, uneven allocation of resources have resulted in problems. Can we do something about this phenomenon such that among clusters they can match one another's services such that waiting time can be reduced? That is to guard against unfairness. So we suggest that a review committee should be set up as soon as possible, and non-HA members and persons who are not officials of the Department of Health should be appointed to the committee. The HA needs reform. Can we do something to rescue it? Of course, Dr. Leung Ka-lau had been saying that no matter what we do, it would be useless. Thank you.
Secretary for Food and Health. President, I'm going to respond to the motion moved by Dr. Leung Ka-lau, that is dissolving the hospital authority, and the amendments put forward by Mr. Fernando Cheung and Albert Ho. Now, I am going, first of all, to talk about the role and function of the HA in local healthcare system. And after hearing members' views tomorrow, I will give an overall reply. In early years, the public hospital system in Hong Kong was not well established. The standard of services varied, and the hospitals were crowded. Many citizens did not get the services they need. In 1985, the government commissioned a consultancy to submit a report to set out plans, development plans for public hospital services in Hong Kong. After deliberation, the consultancy suggested setting up a statutory body that is outside the establishment to enhance the efficiency of public hospitals. The recommendation was widely accepted, and so in December 1990, under the HA ordinance, the HA was set up to provide public hospital services to members of the public. The HA is a statutory body, and at present, through 7 clusters across the territory, we are providing services in hospitals, in specialist clinics, general clinics, and outreach services to provide medical care and rehabilitation services to members of the public. We manage all public hospitals in Hong Kong. We also allocate resources to respond to demand for in public hospital services. We also make recommendation to the administration in this regard. We manage and develop the public hospital system. We plan and build public hospitals. We also facilitate, help, and take part in the training of medical professionals. The HA runs 41 hospitals or medical institutions. We provide 27,100 beds, 47 specialist clinics, 73 general practice clinics. We provide 90% of inpatient service in Hong Kong and 31% of basic healthcare services. Since its establishment in 1991, the HA has continued with our effort to enhance service quality to our patients and to improve the efficiency of public hospital and make sure that no members of the public will be denied medical services because of lack of means. The HA plays an important role in public healthcare sector. We also work with local hospitals to train up professional doctors, nurses, and medical and healthcare staff. Apart from the above, the HA also put in effort to deal with disasters and also to prevent any epidemic outbreak. Our operating cost only amounts to 2.4% of GDP, and yet we take care of 90% of the patients who require secondary and tertiary healthcare needs. We also set up quality system in terms of public hospital services which meet international standard. We also face challenges, for example, the aging population and the challenges brought forward by demographic changes and also the demand for our service across the border, the rising expectation of our patients, and the development of medical technology. All these pose direct influences on our planning and allocation of resources. The CE already said that he will review the operation of HA so as to ensure we can provide service of high quality and effective service. Healthcare is closely related to livelihood. Our service may meet international standard. However, with the challenges I quoted, we do have room to improvement. I will adopt an open mind to listen to members' views on the motion and the amendments. After listening to members' views, I will give an overall reply tomorrow. Thank you. Meeting adjourned, and we'll resume the meeting tomorrow at 9 a.m.